Go ahead and get started. Okay, well, thank you all for joining us today. Good afternoon and welcome to all of you for joining us in this workshop to help the HEAL efforts, which is Help End Addiction Long-Term Strategic Research Plan to develop research priorities that are focused on the research training and workforce. So I'm Cheryl Stucky. I am professor at the Medical College of Wisconsin in the Department of Cell Biology, Neurobiology, and Anatomy. And I'd like to introduce my co-chair and have her take over now, Jennifer Haythornthwaite.
Hi, everybody. I'm Jennifer Haythornthwaite. I'm a professor of psychiatry and behavioral sciences at Johns Hopkins University and co-chair of this subcommittee for the executive committee for the strategic planning. Should we have our subcommittee members introduce themselves?
So I think that's an excellent idea. Okay. So let's go ahead and go in the order that we have them on the agenda.
Oh, good idea.
Yeah. Flavia, would you go ahead, please?
Hi, everyone. My name is Flavia Capos. I'm a dentist and epidemiologist by training. I'm currently an assistant professor at Duke University. Happy to be here.
Thank you. Daniel.
Hi, Dan Claw. I'm a rheumatologist in the Department of Anesthesiology at the University of Michigan.
Thanks, Dan. Jamie.
Hi, Jamie Rudy, clinical psychologist and currently a professor in the Department of Health Promotion Sciences at the University of Oklahoma Health Sciences.
Thank you. Tom Norris, are you on? Okay, I'm not sure Tom's joined us yet, so we can come back to Tom. Eden, please.
Hi, everyone. My name is Eden Buell. I'm a post-baccalaureate trainee, and I'm also a member with lived experience.
Okay, thanks, Eden. Roger.
Hi, Roger Fillingham from the College of Dentistry at University of Florida.
Great. Kate.
Hi, I'm Kate Sadler. I'm an assistant professor of neuroscience at the University of Texas at Dallas.
Thank you. Carolina.
Hi, everybody. I'm Carolina Valencia, clinical associate professor at University of Texas, El Paso. Welcome, everybody.
Great. Laura.
Hi, I'm Laura Frylaw, professor of physical therapy and rehab science at the University of Iowa.
Super. Brian. Yeah, I don't think Brian's on yet.
Yeah, he's showing up. Wait, he may not be unmuted. He's showing up on our list. Yeah.
Okay, great. Brian, would you, if you can, please introduce yourself?
No, he's not coming up.
Maybe he's having a little trouble with mute. Okay, let's move on. Alex.
Hi, everyone. My name is Alex Chemesian. I'm a pain management physician and investigator in the Washington University Pain Center at WashU in St. Louis.
Super. Thank you, Alex. Great. And I think Tom, let me just check. Has Tom come on yet? Or Brian?
I don't see Tom.
Okay.
Okay.
Okay, great. All right. So then we'll go ahead and move on. So the goal of this workshop is to help HEAL develop strategic research priorities that will guide the next 5 years for pain research within the HEAL initiative. And our subcommittee is specifically focused on the research workforce and training. And our goal is to develop a short list of 3 to 5 research topics that we think should be prioritized for the research workforce and training. And so now I'll turn it over to Jennifer to talk about our goals for this workshop today.
Hi, everybody. We opted out of webinar format and went with a kind of a Zoom meeting format because we're really interested in interacting with all of you and hearing your thoughts about our internal discourse. So we've structured breakout rooms Feel free to stay off video if that's more comfortable for you. Feel free to be a fly on the wall. But we really, if you have ideas, we want to hear them. Add them to the chat, speak up if you're comfortable. Also realize that after this, there'll be a period of commentary. So as you reflect on things, you can come back and provide your ideas. But just please hear, we are very interested in hearing from all of you, because while we've been involved in this field for a long time, we want to get really good, innovative ideas. We want people looking at it from the outside and helping us think, because this is such a rich potential opportunity for us in the world of pain research. So thank you.
Great, thank you. So I think this time we'll turn it over to Dr. Giroux. Rob, please go ahead.
Right. Thanks, Cheryl. Hello, everybody. I'm Rob Giroux at WashU in St. Louis. I'm the director of the WashU Pain Center. And in the context of this, I am co-chairing the strategic planning process along with my colleague, Kathleen Sluka, who is in a plane somewhere over the ocean somewhere right now, so can't join us. But she's been working all along with this. I'm also part of the HEAL multidisciplinary working group that kind of takes information and advises on this process. So very happy to see you all here. Really appreciate the effort that you're all putting in to help with this. I'm going to give you a little bit of an overview, if I may, of kind of where we are and where we're going with respect to the HEAL initiative. You should all be aware, obviously, by now with what the HEAL initiative is. It was launched in 2018 with the overall goal of addressing the kind of dual crises of opioid overdose deaths and chronic pain, which were interrelated, at least certainly at the beginning. As I said, it launched in 2018. There's been a total of over $3 billion in investment to date. As you can see, more than 1,800 research projects in all 50 states, and involving collaboration amongst 19 of the NIH ICOs, the institutes, centers, and offices. So it's important to kind of keep in mind what the mission of pain, the HEAL pain research, what the HEAL pain research mission is, which is to reduce pain and the risk of opioid use disorder by developing safe and effective pain treatment and prevention strategies to improve the quality of life for all people. And at the outset, there was sort of because of the very short amount of time between the announcement of the program and when we need to get started, the NIH had to kind of deal with previous strategic planning that had been in place, put out a bunch of RFAs that we felt addressed many of the major goals that fit within that overall mission. All those initial projects are sort of wrapping up or coming to a transition point now. And our goal here, and for the past few months, has been to get public input, broad input, stakeholder input, to help recommend priorities for pain research going forward to the next phase of the HEAL initiative, which really will kind of take place in the context of fiscal year 2027 funding opportunities, which is kind of why this process has been sort of accelerated in getting these groups together. So when I say these groups, let me just kind of show you. So here, this is the strategic planning process. As I mentioned, myself and Kathleen are co-chairing this, facilitated by our lived experience advisor, Michael Falcon. We have 7 different subcommittees and areas that we're working on. As you can see here, health, equity, and pain across the life course, non-addictive therapeutics development, pain biomarkers and predictors, optimization of interventions to improve pain, implementation of health services, and then cross-cutting things like the intersection of pain and substance use disorder, and our goal here today, which is the pain research workforce and training. So every one of these subcommittees is doing a similar process to what we're doing here. We've taken information from the request for information, put together these workshops to get, again, broader stakeholder input to make sure that we're understanding what's working well, what we have missed, what are the big gaps that should be addressed going forward. And you can see here are these workshops, all 7 of these, several of these have happened already. We're the 3rd here today. And we encourage people to attend multiple of these because there's a lot of things that inform across the different areas of emphasis. And of course, a lot of us have a foot in many of these different areas. So there's the link and the code to register for more of these, and I would encourage you all to do that. So after today, so where are we now? Through November, December, we're finishing up these workshops. We'll combine information and input from these workshops together with the kind of written input we got from the RFI that went out a while back. All that will be compiled, and by January, all of these subcommittees are to have come down with a refined set of prioritized areas across these subcommittees. And in January, then all of that information will come to the kind of executive committee for this process. We're going to have an on-site meeting here in St. Louis, and then we will kind of whittle those down and prepare this draft of the HEAL Pain research priorities that will be presented in February to NINDS Advisory Council. That rapid time course, as I mentioned, was meant to enable in March and April for the NIH to develop the strategic plan and begin implementing that strategic plan by coming up with concepts and funding opportunities for that fiscal year 2027. All of these webinars are being recorded, and they're available. There's links going out to those. It's nice. You can go and listen to those in 1.5 or 1.75 or 2x speed if you want to catch up as quickly as possible. But that'll enable people to kind of think and digest everything that's going on and continue to provide input, which we encourage people to do through this HEAL question at od.nih.gov email address to give further input before we move forward. So that's what I have for today. And I look forward to hearing the discussion today. And thank you again all for volunteering your time to help with this process.
Thank you, Rob. That's excellent. We appreciate that much. So Jennifer, I think unless there's something else we need to do, we could move into our presentations.
Yeah, I think we have Brian on. He could
Okay.
introduce himself. Yeah, I don't see Tom yet.
Okay, Brian, can you go ahead?
Hello, can you hear me?
Yes.
Okay, sorry, I'm leaving my lab now so I can get back to my desktop at my house. But I'm Brian, I'm a postdoc at Yale University, and I'm thankful to be a member of this subcommittee.
Thank you, Brian. Wonderful. So if hopefully Tom will be able to join us. He is a person with lived experience and has very valuable insights to our committee and our discussion. So hopefully he'll be able to join us. Okay, so I think we'll move on to our presentations then. I'd like to introduce Dr. Roger Fillingham from the University of Florida, who will speak to us on addressing the leaky pipeline.
Great, thanks, Cheryl. So what we're going to talk about now, hopefully, is going to spur some discussion for our breakout rooms. And we want to talk about how to get people into the pain research area and keep them there, essentially. And I certainly want to acknowledge that the thoughts I'm going to share have been informed by discussions with our subcommittee and also have been informed by previous work that's been done by members of the Pain Policy, Office of Pain Policy at NIH, as well as people in the pain field. So there are some resources here that may be useful for you. And this is not unique to pain, but in the workforce development area, it is recognized that people start down the road of becoming scientists, and somewhere along the way, they opt out or fall out or slip between the cracks. That is, we lose people who could be valuable to our biomedical research workforce. This is true in pain as well as in other areas. You can see these leaks, if you will, occur across different areas of career development, and perhaps the solutions for these leaks are going to be different. One thing I'd like us to think about a little bit today. So first of all, there have been efforts to retain people in the biomedical research pipeline at all of these levels. Some of them are HEAL-specific initiatives pointed out in blue that are really designed to help retain people in the pain research workforce. One thing maybe we don't think about very much is, where is the pipeline emptying out? That is it pouring people out into a wonderful field of rainbows and unicorns, or into a horrifying hellscape of hope and despair? And perhaps the answer is somewhere in between, but what we're inviting people to stay in and to work in is really going to be a critical component of how successful we are at retaining people. And so one question for us to think about is the pipeline really leaking, or are people using escape hatches, maybe for justifiable reasons? So we want to consider that as we start crafting some solutions. And one thing that interests me, this is a small study that was published now 10 plus years ago, but they were interviewing graduate students and postdocs. And this isn't the point they were making, but this is the point I took from this, is that most people don't know what they want to do. They haven't figured out what they want to be when they grow up, even when they enter postdoctoral training, right? So they may be in a pipeline, but they may not know what pipeline they're in, and we may not know what pipeline they're in. So there are many areas in which we can intervene and help people articulate their personal and professional goals, and thereby maybe retain them in an area that they're really interested in. And I know this is about the leaky pipeline, but I don't like the leaky pipeline, if I'm being honest. I don't like it as an analogy. It implies that if we just got people into the pipeline and plugged up all those holes, that the path of least resistance would have them end up where we want them to end up, which is as pain researchers. And I think it's probably a bit more nuanced than that. Secondly, as we emphasize the pipeline, we are emphasizing a specific component of infrastructure, if you will, or components of infrastructure, and not thinking quite as much about the people in the pipeline or other features of the system outside of the pipeline. And those are all important targets for intervention. I think the leaky pipeline, frankly, downplays the agency of the people who are pursuing a research career. They make very active and intentional decisions at all points along their career development, and that should be taken into account. And we also know that the pipeline is selectively leaky. That is, people from certain population groups are more likely to leave the pipeline than others. And that sounds more like a filter than a leak to me. So I think there are other ways of thinking about our research career development and what we would hope to accomplish for the pain research workforce. I personally prefer an analogy more like a highway, right? Where people are traveling along, they have a destination in mind. You can see there are many on-ramps and off-ramps, which seems reasonable to me. And people, if we adopt this highway perspective, people need to know there's a way to get where they want to go, right? They need to know about the route. They need to recognize, and they often do, that there are multiple on-ramps and off-ramps. And if they missed one on-ramp, there may be an opportunity later. We also recognize that along the road, there are many roadblocks that pop up. There are detours to be taken. And we may actually identify alternative routes to get people where they want to go. It's also the case that if you're going on a trip, a tour guide could be helpful, someone like a mentor. And finally, in a road trip like this, both the journey and the destination are important. I know when I've taken road trips, I've opted to take longer routes because they were more pleasant or interesting than the shorter routes. So both the journey and the destination should be considered as we think about how to get people on the road and keep them on the road. So I'm thinking about how to get people on the Pain Science Parkway and keep them there. And most of what I've mentioned so far is not specific to pain research, right? These leaks occur in all areas of career development across the biomedical research workforce. It's worth considering whether there are features of pain research that make it particularly likely that people might leave or avoid us, or that might actually help retain people, right? So some of the challenges of pain research might be that this is a small field. We don't have as much money or as many people or as large a footprint as many other areas of biomedical research. Most of us have no institutional home. That includes at our universities. There's often not, and typically not, a department of pain, if you will. Many of us don't believe we have a home at the National Institutes of Health. And so that can be a challenge for people. Pain is a challenging topic to study. It is a subjective experience, which frustrates many people in science. There is still low public awareness of pain and its impact from a public health perspective. And there is a social stigma around pain that doesn't necessarily affect other conditions in the same way. Now, that said, we have some opportunities in pain, but the public health impact of pain is enormous, arguably greater than any other chronic condition in the developed world. Another opportunity and strength of pain is, in fact, the HEAL initiative, which has brought additional attention and a lot more resources to bolster pain research. We definitely have strong advocates and a committed workforce. And finally, I might argue that the field is ripe for transformative change. So there is opportunity to have tremendous impact if you opt to join the pain research workforce. And so how do we increase the quantity and diversity of traffic on the Pain Science Parkway? Well, as I just implied, we do need to increase public awareness of chronic pain and let people know as early as grade school that chronic pain is a thing. And this might relate to developing feeder programs that are specific to pain research to get people interested in pain research early. Promoting the diversity of career options. I think we'll hear more about that as we talk today. We have a real opportunity to engage people with lived experience of pain. We're joined on our subcommittee by people with lived experience. And when I say engage them, I mean, number one, engage them in training our workforce and in informing the work that we do, but also engage them as professionals who are part of the pain research workforce and give them opportunity to pursue the training that they would like to pursue to accomplish their own personal and professional goals. And of course, this is not specific to pain, but it applies to pain. We want to make sure we have adequate funding and compensation for trainees in order to have them join and continue on the Pain Science Parkway. Some of the challenges to retaining people in pain science include funding limitations and instability that is either real or perceived by the community. We've heard from many constituents, including some of the published work I alluded to earlier, that there are real challenges with making sure, especially clinical scientists, have protected time for research, and that other institutional responsibilities don't impede their ability to continue their pain work. There is often inadequate institutional infrastructure to support pain research. There may be poor quality mentorship, and we want to make sure that the workplace culture and the support for well-being are making pain science a place that people want to stay. And I'll mention that these top two, funding limitations and protected time, are really particular problems for physician scientists who are a critical component of our workforce. I mentioned workplace culture in general. Different factors contribute to a toxic work culture. They're depicted here in the figure: a disrespectful, non-inclusive, unethical, cutthroat, and abusive culture is the epitome of a toxic work culture. Toxic cultures contribute to lots of bad outcomes, and we certainly want to avoid those. This is not specific to pain, but in academia, we might argue that there are some specific risk factors for toxicity, including the hierarchical and political nature of the enterprise, the hidden curriculum that pervades academia, inadequate and unstable funding, which promotes competition and can promote that cutthroat environment. The incentive structures can sometimes promote toxicity, competition, systemic biases, and abusive supervision. As I mentioned earlier, the importance of quality mentoring. And maybe some of these risk factors for toxicity explain the fairly dramatic increases in mental health concerns in students in higher education. These are increases in different mental health concerns from 2013 to 2018. And you see these are quite substantial. And so if we're going to make pain research a place that people will stay, we need to promote well-being. Well-being is strongly linked to academic success. As I just showed, low well-being and mental health concerns are highly prevalent in trainees, but also in faculty. The scientific environment disproportionately affects the well-being of people from historically excluded communities. An antidote to some of these problems is effective mentorship. And finally, some recent research shows that acts of kindness actually promote well-being. And the fact that many of you are saying, why is this academic dude talking about kindness, is a symptom of the problem that we have. And one more set of factors I'd like to highlight in terms of making sure we're able to retain people in science. There are three major factors that predict persistence in science. People develop a scientific self-efficacy, that is, they believe they can do, in our case, what pain scientists do. They develop a scientific identity and begin to identify themselves as a pain science, and then they internalize the values of the science community. And so as we think about improving retention of people in the pain research workforce, we want to think about these as targets, and we can address these through training, specifically in pain research, through quality mentorship and by building community. And so some things we can do to encourage people to get on the pain science pathway and stay there are: one, focus on making both the journey and the destination desirable places to be. Enhance the infrastructure for pain science nationally. Engage people with lived experience of pain throughout the career development pathway and throughout the research enterprise. Emphasize the attractive features of pain science, of which there are many. advance a culture of well-being and support. And many of these things can be accomplished by optimizing mentorship. And so those are the thoughts I wanted to share with you, and I'll turn it back to our chairs at this time.
Thank you, Roger. That was excellent. Really wonderful presentation. And now we'd like to move straight into our second presentation by Dan Claw. And then after that, we will break into groups and ask questions, raise comments, and so forth. So I'm going to turn it over to Dan.
Thanks, Cheryl, and hi, everyone. So I was charged with talking about successes, failures, and gaps. And hardly any of these are my ideas. I'm really reporting what the group had some really terrific ideas in these areas. So the first two slides I'm going to show are Laura Wander's slides that sort of laid out some of the different programs that HEAL has initiated. Some of these still exist, some of them no longer exist, but there have been a lot of different attempts at sort of improving workforce development. And I just want to say thank you to all the NIH program officers that have been so invested in adding all of the training programs to the HEAL initiative. This is a different way of depicting some of these with respect to when they were issued, how long they lasted. And you'll see in my subsequent report that some of the things, for example, the K-24 program that the group thought was a really good idea only lasted a year. And what we're really saying is please bring something like that back. So overall, the successes, again, in general, I think these training programs have been pretty impressive and quite successful. The K-99 R00 program is excellent and needed, especially for non-citizen trainees. And a question is, why is this apparently going away, at least the HEAL version of this? The K-12 program is an excellent addition for the trainees at institutions without established pain research mentors. The diversity training supplements have been very successful and should be continued. The T90 R90 program is terrific, but why is this only for postdocs and not for pre-docs? And similarly, the F31 and F32 programs work, but why aren't more people applying for them? Is there a lack of knowledge where we could make more people aware of these programs and encourage people to apply? And we, by and large, really like the Purpose program. I have to say myself, I wasn't excited about the Purpose program at the beginning, but it's my favorite meeting to go to now, Laura. So congratulations. Some of the issues, this first one, I'll insert a little bit of my own personal opinion because I am a physician scientist. I mentor a ton of physicians, and this is a huge problem. Many clinicians are actually not even allowed to apply for training grants because of the huge difference between their salaries and what's paid for by the grant. In the Department of Anesthesiology at the University of Michigan, we have calculated that if we allow one of our junior faculty to get a career development award, which we have a lot of them, it costs us almost $1 million over the course of that award to pay the difference between what they make in their salary and what the award pays. And it would help a lot just to have, and this is not a HEAL issue, this is a broader NIH issue, pay 75% of the NIH cap for K awards, not 75% of $110,000, because that makes the delta much, much bigger. And it really makes it such that it's very hard for a lot of departments to even allow people. We even have one of our K-12 trainees that her institution made her identify a donor that would donate $1 million to pay the difference between what her salary was and what the K award paid before she could even submit that grant. Many of us think that the pain study section from CSR is great, but because there's so many pain researchers and so many people that apply every cycle, it's really difficult to get a good score on an R series grant that goes to that study section. And this really impedes the K to R transition, which is really one of the most critical sort of danger points for people that are young investigators. As far as funding gaps, I think we all really appreciate how impactful it has been to involve persons with lived experience into our projects. Again, once you start doing this, you'll never go back. But we all need training. Investigators need training in how to best interact with persons with lived experience. Persons with lived experience need additional training to play some of the roles that we're asking them to play. And all of us need additional training and figure out where we can optimally place persons with lived experience. In team science, when I give talks on team science, I say that we really are catering to people's special strengths and having them do what they're uniquely able to do and not have them try to do things that maybe other people could do just as well or better. And in the future, I think we'll get better at identifying what types of committees, where in the projects that we involve persons with lived experience so that they can be maximally impactful, just like the rest of us that are involved in team science are really only involved in portions of a project or of a committee. We need graduate and postdoctoral training programs similar to the Payne K-12, where if someone is at an institution that doesn't have strong mentorship, it would allow them to still be a Payne researcher, stay in or at that institution, but get some mentoring from afar so that they could be competitive with respect to their funding and their research projects. There are not as many training grants for individuals working in the preclinical or basic science space as there are in the clinical workforce on the Payne side. We, again, already talked about this, but we need more K99, R00, or R90 slots to support the non-US citizen. And there are really no funding mechanisms to support individuals with lived experience who want to enter the research pipeline from non-traditional educational or research-focused areas. With respect to mentoring, a lot of us really think K-24 programs are really important, especially for clinician scientists and physician scientists. This often allows people to really dedicate enough time to both mentoring and their science and keep from having to do too much clinical work such that they actually can't be really good scientists because they're overwhelmed with clinical work. And again, there are a lot of categorical institutes that actually do not fund K-24s. So there's a lot of great mentors in the Payne space that wouldn't be able to get a K-24 by virtue of the conditions that they study. Currently, mentoring is clearly variable between individuals and institutions, and so more training on mentoring would be helpful. And we've had a historical overemphasis on people that we train ending up in academic careers. We've more or less neglected the fact that a lot of these individuals we train are needed in industry and policy and communications and other non-research academic roles. We need people trained in Payne that are willing to and able to fill those roles as well. Payne trainees in general would benefit from shorter, low burden applications. And also, if possible, some opportunities to get funding even before they enter their doctoral programs, such in the undergraduate programs. The structural training programs like the R25, we think could be a terrific model, but again, that was only issued for a short period of time. We need a structured Payne curriculum for Payne clinical research, basic science researchers, and for physicians that treat Payne patients. This is a problem, a ubiquitous problem, beginning with the training of clinicians at our medical schools and other health sciences schools. We need to train people in things like communication skills so that they are better able to communicate with persons with a lived experience and diverse audiences, as well as in being more entrepreneurial with respect to how they approach science and how they approach research. And again, as someone who a long time ago was a PI of a Clinical and Translational Science Award at the University of Michigan, where these awards were set up to try to link basic scientists and clinical investigators, we still struggle to do this well at institutions and programs and things like that. We have to get better at this. So I will stop there.
Great, thank you. Thank you, Dan, that was excellent. So at this point, I want to take a really quick moment to have Tom Norris. introduce himself. Tom, would you please introduce yourself?
You're muted.
You're just muted, Tom.
Oh,
Oh, okay. Okay, no
when we
worries.
come back. Yeah.
We can do that when we come back. Tom is one of our persons with lived experience and has brought a lot of great insight to this committee along with Eden Buell. Okay, so now I think we would like to move to our breakout sessions, and hopefully our highly skilled AV team is going to be able to move us into randomized breakout sessions where we're going to be discussing the first two presentations that we heard, and then subcommittee members will be guiding that discussion and also taking high-level notes to bring the high-level ideas and novel ideas back to the larger group when we return. Jennifer, do you want to say anything else?
Nope, I think that's it. We're just please speak up and help us kind of help us by giving your comments and thoughts about what you've been hearing so far and things we've missed.
Yes, absolutely.
Yeah.
Okay, let's see how this breakout room goes.
Yes, so everyone will automatically be assigned to a breakout room, nothing needed on your side. All subcommittee leaders, you'll be put into the breakout room that you were assigned to, and we will converse for about 30 minutes.
Okay, everyone. Welcome back. I think we're all returning from our breakout rooms. Hopefully you had a great discussion, a robust discussion in your rooms. We all look forward to hearing about that. And so what I'll ask, just before we take our break, I'll ask the designated leader from the room to synthesize the high level and novel points that were raised and to give then a synopsis of that when we get back into our larger group discussion right after the break. If you could keep your comments to between 2 to 3 minutes of the high level points that were made in your breakout session, that would be great. And then that will allow us enough time, or hopefully enough time, to really get into the discussion. And we also could continue this discussion into the next larger breakout room if needed. Okay, so everybody clear? Any questions? Okay, then please take a break and please come back at 2:30. Thank you. Okay. Hopefully everybody got a chance to do a little bio break, and thanks for coming back for our larger group discussion and reporting from our breakout rooms. So in this 30-minute time period, we'd like to hear high-level, novel ideas, most important ideas focused upon in the breakout rooms, and then we'll have a general discussion about that thereafter. So now I'd like to ask each of the breakout room leaders to give your high-level synopsis in 2 minutes, 2 to 3 minutes. So I think we could start out with breakout room number 1. Roger, I think that was you.
Yeah.
Okay.
Yeah, so we had a great discussion. One point that came up that hadn't previously surfaced was the value and importance of trying to retain mid to late career investigators who may leave for other opportunities like administration, and things like a K-24, as Dan mentioned, are super helpful here, but also mentorship for people at this stage is really important. Collaborating with people with lived experience, and we've talked about this, but we talked in our group about sort of bi-directional collaboration so that they can engage with us on the research side, and we can engage with them on communicating back to their constituents or to other communities that they work with, some of what's going on in the research space. Building infrastructure that's stable so that people have a sense of things are going to be sustained and there's some persistence to the work. Building in quality mentorship to help early career investigators build skills and resilience in terms of insulating them from some of the challenges. And one way to get there is to provide mentorship training to enhance mentorship. And then we raise concerns about physician scientists, and we're almost at the cusp of solving the problem, and the breakout room ended. So apologies there.
That's fantastic. Great job, Roger. Glad that we're going to look forward to hearing your solution to that. Okay, so now I'd like to move on to group 2. And Dan, I think you were leading that group. Please go ahead.
Yeah, so Roger, you must have a huge bag of money if you're going to solve that problem, I think. So, our group had a lot of different interesting discussions and comments. We started by talking about some of the issues that people have, especially later in a career development award, with having enough funding to do the research that's going to yield them to be able to make the K to R transitions. There are some NIH institutes that have R03 specifically for people on K awards. These are really helpful for those individuals. And something else that was brought up was using admin supplements. Those are typically used for R series awards and larger awards, but those would give NIH program staff a little bit more latitude to, again, add something at the end of a K award to so that people have a little bit more research funding to do what they need to get that R series award. We had a lot of talks about appropriately engaging, involving, training our persons with lived experience. I was happy to hear that Eden wasn't bothered by what I said. I think she more or less agreed with what I said. But we talked a lot about this, where again, we all have to. We're new at this. We're all learning how to optimally engage and involve our persons with lived experience. We need training on all sides, on the investigator side, on the PWLE side, and on the people that set up committees to know when to put a person with lived experience or two on the committee, and when maybe that isn't as helpful. One of the really interesting points that Eden brought up that I was totally unaware of is that as we move towards compensating some of the PWLEs for their participation, some of the individuals that are on disability are not able to take financial compensation, or they'll lose their disability. So we have to think of creative ways of compensating people in non-financial ways for them participating, in these things that we're asking them to do. And then finally, in response to a question that was asked, we came up with a derivative idea. A couple years, HEAL gave some money to some of the categorical institutes and who put out NOSIs, Notice of Special Interest, for training supplements to their existing T32 grants. And the only way you could get a training supplement to your existing T32 grant was to suggest a trainee who was going to do pain research. But this would broaden, because there's so many T32s in rheumatology and all other disciplines, that would broaden without giving new T90, R90 programs or new pain T32s. It would give us all sorts of slots at all sorts of institutions that don't have enough pain mentorship at all to get one of these grants, but who could in fact support these people with respect to their mentorship. So I thought that was a really good idea. So, and that's it.
All right, great, Dan. Thank you so much. Okay, so we'll move to group number 3. Laura, would you please take it away?
Yes, actually, Stephanie's going to provide our summary because she was taking notes, and
I'm gonna,
might be
yeah.
the person.
I'll kick us off, and then Laura can jump in with any other details that I'm missing. So I think we had 2 major themes that kind of emerged in our group. Really, the main one is the kind of lost child aspect, which one of our members really eloquently put it. Said that pain is everywhere and nowhere, not in terms of just at the NIH, not having a specific institute there, but really at institutes. Like, there are not pain departments. And many departments like epidemiology and biostatistics just don't have people in their department that are pain researchers. And so just some of those barriers to getting on the road to pain research or staying on it are logistical, like within institutions. And again, broader in terms of in society, in clinics, again, pain being everywhere and nowhere. And the other major theme was creating more opportunities and getting trainees interested and educated about opportunities pre-doctorally, so that we could get people on that road to pain research sooner. And also just, I think there was expression of just trying to make those opportunities easier to find more generally and in terms of very specific opportunities. And then we did talk a bit about the kind of overall stigmatizing of pain in society, and part of how that manifests is gaslighting of patients. And a member talked about how that actually has ripple effects on the training pipeline or road as well, and that overall stigma. We did hear from several members about things that were working particularly well in pain research. The feeling that kind of toxicity of workplace and training is certainly not specific to pain, and in fact has not really been felt. Like the feeling is kind of that the pain research community is pretty welcoming and open, and particularly people had great things to say about the Purpose Network and about the Purpose meeting in particular, where they are really a lot of opportunities and networking opened up to them. Laura, I think those were my main notes, unless you had anything to add.
No, just to that last one, also the K-12, the HEAL K-12 being
That's
another
right.
example that they thought was really working well. But,
yeah, the opportunities for training in mentorship and how to recognize a good, healthy mentorship relationship, and all of those early on. A lot of stress on early on the road.
Yes, perfect. Thank you, Stephanie.
Great. Thank you, Stephanie and Laura, for that great summary. And now we'll turn to group number 4. Jamie, please take it away.
All right, thank you. Yeah, we had a great little discussion as well. Unfortunately, we did not solve it, as Roger's group was on the cusp of doing. And a lot of our discussion did kind of overlap with some of the other groups, but let me see if I can highlight just some of the idiosyncrasies here. So one that is related to what group 3 was just discussing is really how can we increase the visibility of chronic pain as a public health concern, in the same way that smoking or other health behaviors is really made known, right? And so that just raises the visibility out there that this is something that people study. It's an important issue. And then also doing things to advertise or get the word out that pain science is a career. You know, some of the discussion was you didn't really even realize, first of all, there's not much training, if at all, except in very specialized, a few universities where you can receive classes in pain as an undergraduate, much less a graduate student. And so how do you get the word out really to make it known that you know, you can have a career in pain, right? And myself included, didn't know really anything about pain until I got to graduate school, and that's kind of late in the game. So that's one. So increasing the visibility of chronic pain as a public health problem and pain science as a career. And related to that is just, you know, once you do identify that pain science is something that's interesting to you, how do you identify mentors, maybe outside of your university, that can help you move on to the next level, because maybe there's just not enough mentors within the university that you're at. And then down the career path, not seeing, there's not enough visibility in the pain research positions that are out there. So making it known that there are these positions out there, you know, that we're obviously trying to increase the workforce to meet the demand of that, but there's a perception that maybe there's just not enough jobs out there for those people who are interested in pain. So that was one of the issues. An issue that we did talk about, second one is, I mean, of course, highlighted by all three of the previous groups, and of course the speakers this morning, about how do we increase pain-specific funding for mentoring and training, with maybe a specific emphasis on earmarking pain-related T32s, and also increasing training in high schools through the K through 12. You know, that part of the pipeline that we hardly discuss or think about at all. Not going to talk anything more about that. And then the third one is really, what can we do to lower the barrier into the pain workforce? And so that was somewhat echoed in the earlier presentations about doing things to provide training opportunities or grants for undergraduates moving into graduate school, and not having the barrier as high as something like an F31, but also how do you lower the barrier for someone just entering graduate school who wants to develop pain training before they get to the dissertation stage. So the F31 is great for the dissertation stage, but how do we really fund students earlier than that? And then related to that is how do you develop mechanisms or build opportunities that don't require a lot of pilot data, right? So that again helps entry into the workforce a little earlier, because it just doesn't make the hurdle so high. I think that hit most of the highlights of our discussion. However, I'm happy to have my colleagues hop in and say anything else that I might have missed.
Okay, thank you, Jamie. That was excellent. Do any of the subcommittee members want to quickly add to anything that was raised or not raised in the breakout groups? Highlights. Okay. All right, then what I'd like to do at this point is open this up to a general discussion of all the things that you just heard about these critical points that the breakout discussion rooms really thoroughly talked about. So please, I'd like to open this up to everyone now to raise your hand, and we'll hopefully see your hands raised and let you speak. Brian, please go ahead.
Yeah, thank you. And something that we talked about in our, I was in group 3. You know, we had the whole discussion about pain as kind of like the lost child in the realm of scientific home bases. And something that I was just thinking about that I wish I would have said in the group was you know, maybe collaboration, thinking of like, how do we collaborate with other groups of or consortiums of researchers, like myself. I'm a cancer researcher, and but I also study pain. So I'm thinking, maybe is there a way for us as pain researchers to build those collaborative relationships with centers focused on like cancer or metabolic diseases such as like diabetes and obesity, and bring ourselves into those folds so that way a lot of these institutions already have some sorts of programs that cater to that type of training, and that's how we might be able to increase the visibility of ourselves as pain researchers, saying like these are some common diseases, chronic diseases, or disorders that people might have, but you know what, they're also co-linked with pain. And if you're interested in studying how pain contributes to those diseases or how those diseases might exacerbate pain, we are the individuals who would be involved in that. So just a brief thought that I had.
Yeah, Brian, that's a great point about how to better build bridges with existing infrastructure and centers. Excellent point. Others? Don't all talk at once now. Laura, please go ahead.
I was just thinking that I am hearing what I think of as sort of two buckets, and one of them is, of course, funding, right? So mechanisms of funding that encourage any of these, whether it's at the pre-doc level, post-doc level, early career, et cetera, mid-career, which is all dependent on getting the money that's then earmarked accordingly. But the other part, I think, speaks to what like Brian was just saying, and we also heard in our group, as I'm echoing as the same group, but mechanisms much like what the purpose is trying to do, but things that aren't as dependent on funding, but training on mentoring, training on finding the people. We had an individual who was in an area, because pain is multidisciplinary inherently, of finding people who can serve as these mentors cross-disciplinary, bringing people into the fold. And so I think it's that balance of things that require money and things that, well, everything requires money, but like that needs more money, and things that maybe don't need as much money, and need other kinds of just awareness and campaigns for increased awareness or connecting people as a focus. So that's the themes that I'm hearing. So for what it's worth.
Yeah, that's good. That's a really great point, Laura. Dan, go ahead.
Yeah, because we do have to come up with 3 to 5 recommendations, I want to put in a special plug for K-24s. Because I'm old, I mentor a lot of people that are mid-career, and I've convinced many people to write and get K-24s, and they're just wonderful awards. Usually these people would have become division chiefs or department chairs or gotten more involved in administration of the clinical enterprise, and the K-24 award allowed them to be mentors and to keep their science going and everything like that. And so I just really want to call that out. I think that that it was only 1 year that there was K-24s for HEAL. A bunch of institutes don't offer them. So there's tons of people right now that do pain research that a K-24 isn't in play because they study a pain condition where that institute doesn't issue any K-24s. And so I just want to make the plug. It's not self-serving at all in any way, but I just think it's a really important program, especially for clinician scientists that otherwise that are in danger if they don't get an award like that.
Great point. I think Rob, you have a response to that?
Yes. I'd like to reinforce what Dan is saying, but just encourage this group to, as we're delivering priorities, it's not necessarily to say K-24, K-99, et cetera, but what is the gap that the K-24 addresses that needs to be supported? That's and what is now missing from that. I understand that's a really easy way to frame it, and it's what we all fall back to, but I'm just trying to make sure that we're delivering the message in the way that needs to be received. Where is the gap that the pain field is missing? And I don't know, to me, saying K-24 is a really easy way to do that, but I want to make sure we're doing it how it needs to be received. So we just need to think about that. And that'll be part of the process as we collect all this and make sure that as a larger group, we're delivering it, but just to be thinking about framing things that way. Thanks.
Great, thanks, Rob. Carolina, please go ahead.
Yes, so this is an idea from, I don't know, 4 minutes ago, but we were, in our discussion, we were talking about the sense of belonging, about pain researchers in the pain field, that you don't have this house, right? And I think that's very common across different people working in pain. So one of the items that actually put as a summary, increased visibility and awareness of the HEAL initiative as a dedicated home for pain research community. So, and that's part of what Purpose is doing. I think Purpose has a huge platform on doing something like that. And perhaps Purpose right now could target, or one of its initiative could be the mentorship, because we have so many initiatives that are mentor driven. The mentor is good, so the initiative is good. But if we don't have that platform for providing good mentorship, it's very complicated to really scale this up. And we're going to have the good mentors that we're pointing them out, right, with the fingers. But if we want to go massive, we really need to scale this up, and we need to have a platform for that. So Purpose would be excellent for providing that platform for mentorship and resources for mentors that are not, for example, in entrepreneurship, but you have some mentees, you don't know how to access to that type of information. So Purpose could give that option. Just a thought.
Great point, Carolina. Thank you. Brian.
Yeah, something I was thinking about. So I'm a preclinical researcher, meaning I mostly work with animals. I don't really work with a lot of clinical patients. But something that I found was really impactful during my training was I took time to actually like work under palliative care physicians so that I could, you know, get to meet patients and talk to them about their lived experience and how having access to these types of treatments improves their treatment and their recovery. And I'm wondering if maybe that's something that could be maybe like a program or a type of funding mechanism. I know specifically for a lot of my other preclinical researchers who were graduate level trainees, that wasn't something that was always open and available to them. And also as a person of color, you know, I met with a lot of underrepresented minorities in the clinic. And I think, you know, having that connection and understanding that there are people, that there's representation in multiple facets in terms of the research in pain and treatment, you know, we can start to maybe encourage people to be more involved with like clinical trials. They'll feel more comfortable at their doctor's office, if they know that they're interacting with, you know, other people who like might come from similar backgrounds. I would really like to hear like Tom and Eden's perspective on that. You know, just having researchers who are representative of these different groups, but also, you know, you have the scientists and the physicians meeting with these patients and learning about like what it's like to actually live with that condition and what it's like to deal with pain, and what it's like to go through that treatment process. And I think that's something that could be encouraged through, like I said, programs or funding mechanisms for specifically trainees, I think would be like very, very helpful.
Brian, that's a great idea for shadowing. I think that's a terrific idea. Eden or Tom, do you want to respond to that?
I'm trying to look something up for you, so I'll send it your way. But there's, I think it's more like this idea of having like a group office visit. So taking individuals who have, it's almost like, think about it in a way of like having like a pain group, but instead of it just being a pain group, it's actually like a doctor visit. And so I know Isabel, I'm trying to think of her name, at UNC, she actually studies that. So I'll send that to you, but that's an idea I had. And also, Brian, just thinking about it, like we had mentioned this in our group a little bit about, where's a safe space for people with lived experience who are already researchers, right? And where can they go to get that support? But yeah, I'll get that information over. That's what I have.
Okay, great. Thanks, Eden. Okay, wonderful. Roger, go ahead.
Yeah, one topic that came up in our discussion was the issue of stability. I mean, it's nice to have funding right now, but if we're going to build a workforce, we need people to perceive that pain research will be around for a while and that it's a good idea to go into this area. I don't know the best strategies for doing this. I wouldn't argue that stability is what comes to mind right now at the federal level. But as we talk about building strategies, trying to build some sense of persistence into them, I think would be helpful.
Yeah, really good point, Roger. Great.
To that,
Amber,
can I
go
just
ahead.
follow up just one brief point based on what
Yes.
Roger just said, which I think
Okay.
is an extremely important point. Witness the comments we've had about the K-12s, the K-24s, the K-99s. That's been feedback with respect to some other HEAL programs in the past that when it looks like things are going away, people kind of back away and say, well, I was going to put effort into this area. So I think that is a very important point.
Yeah. Great. Thanks, Rob. Amber, please go ahead.
Hello. So I've talked, I'm currently a trainee. I'm in epidemiology, and I've talked a few times about how the lack of, I guess, like pipelines in terms of there aren't that many faculty in the departments that I guess have received my training in makes it a bit more difficult to advance further. But thinking of it also in another sense, in terms of like increasing visibility, I'm thinking, as a pre-doc, I'm not very familiar with what it means to have like secondary appointments or appointments and other things. But for example, the epidemiologists who do not have appointments in epidemiology, or the bioinformaticists who don't have appointments in bioinformatics because they have their appointments in, for example, anesthesiology or neuroscience. Like that hinders access in terms of me receiving training, but also if on the flip side, a lot of people enter, I guess, like these tool-based fields like epidemiology, biostatistics, etc., without necessarily an idea of what kind of disease they want to study. They are there to learn tools. And if there was a PI on the faculty website who studies pain, then that's, I think, like a simpler way to increase visibility and get people kind of exposed to pain research early on, when maybe they didn't even know it was an option because they didn't know anyone in these sorts of fields who did pain research because they're all officially appointed in other departments.
Yeah, that's a good point. Very good point, Amber. Great point. We have 1 minute left. Would anyone like to raise another comment? Go ahead,
sure.
Brian. Oh, sorry. Brian and then Alex. Go ahead, Brian.
Okay, yeah, mine's just really quick, kind of addressing what Amber said, but maybe some sort of website or collection or collective that we could have where we specifically highlight these types of niche pain researchers. That way we can give visibility to individuals like Amber who are searching for these types of individuals to do their research under. So I think that might be a little helpful.
Good idea, Brian. Thank you. Alex.
Yeah, I just wanted to quickly respond to that comment earlier about bringing kind of bench and non-clinical researchers into the clinical environment. Since I've started my clinical practice in the last few months, I've brought several of my colleagues here from the lab, and it's been a great experience, and I fully support that. And the outcome or the conclusion of that is that The trainees find that they have a greater motivation and appreciation for the problem that we're all studying, but also a refocusing of what they thought was important, right? My patients don't show up with a CFA injection, and they're like, oh, that's interesting. And so I think this is like, especially because we're dealing with a disease that is an experience and a perception and not like an aberrant piece of tissue that doesn't really necessarily require a face-to-face interaction. I want to just encourage the clinicians in this audience, but also kind of maybe make it more of a supported thing at the NIH level to bring trainees, especially those who are non-clinical, into the clinical environment. I think it's a win for everybody.
Can I
Great,
just
thank you, Al. Go ahead.
Can I say something that I actually forgot to say in our group, and I think is really important for the future of our workforce is team science. I think it's a priority. We're not going to be able to move forward if we don't learn and think about, basically train our trainees in this model of pain science and pain as a team science, which speaks to all the things that have been said, but I don't think that has been specifically said. And obviously, again, I'll just echo the mentoring is super important at all stages of really in the pipeline, right? So even mid-careers and, you know, sometime late can use mentoring, but.
Yep, absolutely. Great point. Jennifer.
Yeah, one final point, because I think we need to move on probably in a minute, but Tom made a really nice point in the chat about, so you might want to look at the chat, but he says, I think the PWLE should be the ones to push for public awareness of chronic pain and by default push for sustained research. Part of this push should be the recognition of the benefits of pain research. This means that current research information and finished research information needs to get to the PWLE in public faster than the 13 years it evidently takes. Thank you, Tom. And really, I mean, I think that's where it becomes this wonderful dynamic, productive conversation between the two ends of the spectrum, because it is a spectrum, as we know. Researchers have lived experience with pain, and people with lived experience want to become researchers. So.
Okay, that's great. Yeah, absolutely, Jennifer. And thanks, Tom, for that point you made in the chat. So Jennifer, with that, I think we probably should move on to the next agenda item.
Okay, that's my talk. So let me share my screen. And okay, so I'm going to talk to you about some examples, two examples that we talked about in our subcommittee of successful workforce development. And so the first example is pain research centers. And so what I did over the last week, few days, interviewed 4 of our pain research center leaders, Michael Gold at University of Pittsburgh, Roger Fillingim, who you've been hearing today at the University of Florida, Tonya Palermo, who is a pediatric pain specialist at the University of Washington, and Rob Giroux, one of the co-chairs for the strategic planning from WashU. And so what I did with the pain research center leaders was I asked them, the first thing I said, what have been the top factors, events, programs, activities that have been the most influential components in helping you develop your center? And one of the things that they mentioned really uniformly was institutional support from leadership. And that included both financial and moral support for building a center. In some cases, resources to recruit faculty and comprise packages to offer them, to attract them, and even compete with those faculty to come to their university versus go to another. That support has been sustained over time and even across leaders. What that does through that high-level support is it engages multiple kind of factions and groups within the university. And so that's divisions, departments, colleges within the university. The other thing that they talked about that was, I think, really important was when NIH moves, universities listen. And so, and what I mean by moves, when they offer funding in certain areas, and so that's been a huge benefit of the HEAL initiative, is that institutional leaders are paying attention. And it validates the importance of pain research and indicates that it is a growth industry for the university. And so that, again, So it kind of facilitates that support and that engagement of leadership, which part of what we've been talking about so far are some kind of leadership issues that I'm going to bring up. The other component of that institutional support from leadership has been, for some of the centers I talked to, CTSA resources. And that includes space and other kinds of CTS program items. Another top factor was having a strong leader in charge of the center. And that's the person who leads the center. They're valued in their primary department. They're a leader in their primary department in most cases. And some of them have institutional roles, which takes them outside of leadership within their department and within even their college to the larger institution. And that strong leadership, from what I heard from them, what that does is that brings kind of a collaborative, interdisciplinary kind of tone to the center, which helps build that kind of approach to pain science, which we know is so important. These strong leaders are productive. They have longstanding our support and other mechanisms. They're also generous with their financial resources, and they advocate strongly for recruitment and additional resources. And as one person said to me, success breeds institutional leverage and resources. So as the centers become more successful, it kind of encourages the institution to to provide more resources, and the leaders use that success to leverage resources. And then the final component that really kind of was the richness of the disciplines represented in their faculty. And so the people in the faculty in the center share a primary interest in pain research. Those faculty develop strong partnerships and start collaborating on grants and other kind of research projects, non-funded projects, pilot projects, as well as education and training. So they create a very rich environment that shows a commitment to pain science through kind of weekly seminars and journal clubs and other kinds of activities where people get together. Some of the centers have developed curriculum and courses to make sure that disciplines that are less familiar with pain research, pain science can become educated. And then additional factors that they talk about, what in terms of things, kind of internal or external resources that they think would be required to help their center develop further. And a theme you're going to hear from me is kind of centers and center mechanisms that allow there to be what we were just talking about, which is a sense of kind of sustainability and stability and longevity to the kind of to the center or to the research group. And the other part of centers that you'll hear when you hear about my conversations with the cancer leaders is that centers tend to be multipliers. And so something that can be really incredibly valuable in terms of helping us build our workforce. They also talked about another kind of factor were pain-specific training grants. And there was a real sense that we need to encourage the expansion of the T32, which is both graduate students and postdocs. And on the T90 part of the new program, because it really allows for the hiring of international postdocs. And we've had that discussion in our subcommittee about the kind of the NIH constraints on hiring non-citizens, but still that can be particularly important. I'm getting a sense, particularly in some of the basic science centers that we have, basic science labs that are part of these centers. And then another idea that was discussed was the idea of funding investigators rather than projects. And so something like the Canadian Research Chairs, and really thinking about this across all career stages. And so really the idea of funding people rather than projects. So then I also asked them what has contributed to retaining their trainees in the field generally, not necessarily at their center, but generally. And really what they identified was a sense of kind of the community that their center provides, where there's a lot of contact with faculty throughout training, there's effective mentoring, there's a kind of a comprehensive preparation to be successful in pain research, and especially for those who stay in academia and go out, they may not stay at the center they were trained at, but they go on the job market and are competitive, that they've really kind of been well prepared to be a competitive job applicant. So the second part of what I did was that I actually let me go back. So one of the things that I wanted to add to this kind of sense of community is that that one of the themes that I heard from these discussions was that the current structure for pain centers has kind of a siloed structure that most medical schools have. So most medical schools, they're clinical departments, they're basic science departments, and each department has its own resources and kind of conducts its own business in the sense of recruiting faculty and things like that. What happens these days in most pain centers is that there's an undercurrent of competition with the home department for the faculty. And so I think Amber's discussions about epidemiology are a good example. And you'll hear when I talk about the cancer centers, biostatistics is another example. But what happens is that if I'm and I experience this myself, so I'm a psychologist working in Department of Psychiatry. So when I interact with my pain colleagues, if I'm going to bill clinically, it needs to go through the Department of Psychiatry because that's where the finances are located for my work. If I get a grant and I'm the PI, the credit for that grant goes to my Department of Psychiatry, even if I've got an NPI, if I'm the corresponding PI, things like that. So the kind of the inherent competition, that the siloed structure, I think is really something that we have to be thinking about. And I think it's part of what we've experienced with NIH also, with the siloed kind of institutes and centers. And so HEAL is breaking that, but we really have to think about that being a sustainable breakage so that things don't slip backwards. The other things that the strong centers do is that they attract students through collaborations and productivity, and they really enable kind of their trainees to receive this comprehensive training that I mentioned. Okay, so the next thing I did was I talked to 4 different cancer center leaders from the US, and this was all very short term, so I would have loved to talk to more and get a better kind of database for this discussion, but we're going to have to go with what I've got. And so this is a sense of how big the cancer centers are in the United States. There's 71 of them. 13 are cancer centers, 51 are comprehensive, which means they meet NCI standards for research, clinical care, and education, and then 7 are basic labs. So huge program that NCI has been funding for decades now. And these are the kind of areas, work that these cancer centers are doing in terms of biology, genomics, public, all the way to public and global health and health disparities. So really broad range. The cancer centers I spoke to are Amy James at WashU, Lee Nadler at Dana and Harvard, Bill Nelson, who's at Hopkins, and Naila Salama at University of Washington. And again, ask them what have been the top factors that have contributed to them kind of being able to develop and grow a workforce that is so interdisciplinary, collaborative, productive, and large. And so one of the things that they talked about was the community factor. And so they have a strong kind of local interdisciplinary community of clinicians and scientists who collaborate and develop ideas in teams. And this has really allowed them to develop both breadth and depth of research and build a very strong field. And not all cancer centers specialize in all cancers, but the sum total has really covered a very kind of impressive array of aspects of cancer. They talked about that sense of community is again kind of what we heard from the pain centers, kind of local programming to facilitate collaborations, idea generation, innovation. They've gone much further than I think most of our field has gone. They do grant writing workshops, journal clubs, Ames grant writing. They do mentor training, both individual and peer mentoring. They have systems in place that guarantee that early faculty coming in have a very kind of a mentoring plan and a systematic approach to what they're doing. So they really have a very strong sense of community. They also have enjoyed tremendous funding, and this funding has allowed them to, and as Yenisel was pointing out, the funding requires team science, and it requires that team science across the full range of cancer research, from basic to translational, clinical, and to population health. So it really, it mandates that this be kind of covered. And this funding provides infrastructure and pilot grants and career development funds. And they also encourage and sometimes require institutional matching funds. And all of that has helped the cancer field gain credibility within the institutions. Again, something that I think we need to work on in pain. Attracted foundation money from, so not just government money, but foundation nonprofit money. This whole mechanism kind of forced people to sign on to coming together and working together and collaborating. And then one of the things that one of the cancer centers mentioned was that this whole idea of funding centers is that not all centers get specialized funding. But the specialized funding is only available to the institutions that have a center. So what you can do is you can kind of fund centers, give them resources, get them started, see how they do, and then if they do well, they get more resources if they can successfully compete for those additional resources. And then finally, they talked about the kind of the importance of a huge variety of training mechanisms, and from small to large dollars, dedicated to education and career development, and really encourage workforce development starting very early. And so let me show you kind of what this is from the NCI page on training, and this is the range of training opportunities that NCI currently has available. And you'll see quite a number, some of which we're familiar with, some of which we're not. But then the other thing is that this, and I forget what CRT, because CERTEC, I'm sorry, I can't tell you what that abbreviation stands for. But a lot of the cancer centers I talk to have CERTAC programs that are going into high schools. And they're also setting up post-baccalaureate programs to attract people who want to go back to medical school, and capturing them during that post-baccalaureate training that they might do in science after majoring in something that doesn't give them the credentials that they need to apply for medical school. So again, more of that theme that we've been talking about. Just stop. Okay. Then I asked them also, these 4 center leaders, what additional factors besides those 3 main, and they talked about cancer center finances being an important source of additional funding. So this goes to our discussion about the physician scientists. So cancer centers are very strong financially, and so they can kind of use their resources, their financial resources, to address some of the shortcomings that come up in other fields of research and for other faculty salaries. And so my impression is that oncologists probably don't get quite the salaries that, for example, an anesthesiologist or a surgeon would make. So these are kind of, the salary issues are discipline, to some extent discipline, flexible and specific. Another thing I heard about was working with state agencies, local schools, and community colleges to develop educational programs, again, to kind of get people contact with them early, and really try to engage them in the importance and the value of cancer research, and really early in their thinking about what do they want to do when they grow up. And then the CTSA network, the KL2 series, was particularly, most of our institutions prioritize physician scientists for the KL2 spots. And that seems to have been a mechanism that they've been able to use for their physician scientists. So How have they retained investigators? So one of the things that's interesting that I heard from one or two was that the cancer centers have strong industry relationships that enable faculty to have fluidity as they might move into industry from academia, and then might come back to academia and then move back to industry. The other thing, going to Amber's point and some of the other things we've been talking about, is the cancer center, at least for many of these centers, is its own entity in terms of financial and administrative and within the medical school. And so what happens then is that the faculty, the biostatisticians, the epidemiologists, the psychologists, all these different disciplines that might in other structures have a competition with a home department, their department becomes that unit of the cancer center, or in our case at Hopkins, Department of Oncology. And so creating that home can be a really kind of important part of then having somebody feel like they have a viable career in pain research, or in this case in cancer research, because they're really working with colleagues. They have lots of opportunity for collaboration. They're working with colleagues who value their work and therefore will weigh in around important evaluation components, like working up the academic ladder for promotion. The other thing is that they talked about really gearing resources to for early investigators that would empower them and contribute to the success in competing for funding. So they have a whole variety of programs that they've developed around mentoring, institutional programming that is focused on leadership, developing grant writing workshops, other kinds of soft skills, or skills that are not developed in usual training programs, but are critically important for somebody's success as an investigator. So, so just to summary, the lessons learned from these conversations I had, and for discussion in the breakout rooms, is that first, first point is that NIH and institutional leadership is critical for the formation, for us to think about the long-term workforce of pain. We really have to think about NIH leadership influencing institutional leadership and working on both sides of that. That funding and building strong local communities that develop investigators, that community feel, and investigators' identities as successful pain researchers, kind of like what Roger was talking about in terms of the literature on self-identity of early investigators. Reward interdisciplinary approaches and mandate that they be translational across a full spectrum. And then emphasize education, training, and career development across all career stages, even starting in high school. So with that, I will thank our pain centers for spending time with me to do this.
Okay, thank you, Jennifer. That was excellent. And I know how much hard work you put into interview like at least 10 people over the last few days. Incredible work. Okay, now let me see if I can share.
And it looks like Jamie thank you, Jamie, put in cancer research, training, and education coordination.
Perfect. Okay, great. So I'll move right into the last formal presentation. And what we've tried to do here is to begin distilling the ideas that we've heard in the talks so far today, as well as this rich and robust discussion that we've had with all our breakout groups. And we hope to continue that with our breakout groups. And the idea is really to figure out what are the themes that have run throughout all of this discussion for further development for these priorities that we will ultimately recommend to the HEAL administration. So how really now are we going to merge and go from all these issues and problems into solutions? So that's what my talk, and it'll be pretty short, but this is kind of where we're at, or where we're thinking right now, and we want to get your feedback on. And this is certainly by no means a final set of goals, but it's a work in progress. And so we're thinking that one of the goals, and this is in no particular order, but one of the goals is really to continue to expand career development awards that support pain researchers across the spectrum of all career stages. And also we need to increase the visibility and awareness of these programs. So as several people have pointed out, we need to get people involved even at the high school age level or even before, get them involved in pain research, take that throughout undergraduate, and help identify funding mechanisms, even if they take a gap year or two, to keep them interested in pain research. We need to consider involving people with lived experience in our awards and help and funding them to contribute. We need to support our trainees across all developmental stages, from early to mid to late career. And in particular, we heard of a lot of loss of people at the mid-career level and a need for mentoring of people at the mid-career level. And then to engage people in pain science, include people that are involved in other disciplines like engineering and public health. So a second goal could be creating an enduring program that prepares our pain researchers at all stages of career in very strong leadership skills. So we heard from Jennifer that one of the key things that pain centers have identified is they're all led by a very strong leader. Well, we need to cultivate those strong leaders. So we need to create a mission and a vision, help these leaders learn to do that. We need to help them with learning to do strategic planning, how to negotiate, how to do financial management, and how to create teamwork and engage interdisciplinary collaboration with other institutes and centers to address pain problems and other diseases. A third goal is to provide opportunities for researchers across the spectrum of pain research to have protected time to improve and implement mentoring for the next generation, and also to increase the diversity of pain researchers. So we've heard multiple times that we need to improve the way we provide protected time for physician scientists. That is an absolute critical thing. They are, in my view, a dying breed because we don't have enough protected time for them. We don't have enough support from the Institute for them. So for example, having commitment from administration to cover the cost differential for clinician researchers to help cover the RVUs that will be lost when they're doing research. To have longitudinal research training during the clinical years, to create mentoring programs for all trainees at all stages, and to create programs that invite people with lived experience to participate in our research and that train both the researchers and the people with lived experience how to cross-engage in a very healthy and helpful way. And then to facilitate cross-disciplinary mentoring. A fourth goal could be to provide and support opportunities for researchers to understand and engage in all types of careers, including non-academic careers. We often hear from our trainees that really the only thing that is highlighted in our training programs is an academic research position. But we think that we need to increase the visibility and the support for going into industry, biotech, biopharma, increase the support for going into teaching and provide courses that help our trainees learn how to teach effectively at the undergraduate and graduate level. Encourage people to go into science writing and science reporting, to report to and communicate with the lay public. This is a very effective career and a potential career for our trainees. And then one thing that I think is really missing is how we communicate with the lay public. And I know Tom and Eden have both talked about this, and that there are definitely ways in which our individuals with lived experience can really help us better communicate with the lay public to really tell them about all the excellent, great research that's going on. A fifth goal could be to encourage the full range of translational research from T0, which is the most basic type of research, to T5, which is advanced clinical trials across diverse pain conditions. And that includes rare disorders like things like Fabry disease and Ehlers-Danlos and things like very rare disorders. Throughout consistent requirements, using consistent requirements and grant mechanisms. So some of us have talked about, we can really think about how to build more creative bridges between basic scientists, clinical scientists and researchers, people with lived experience, and then the broad community and the broad public. A sixth goal could be, we all know we need improved funding and improved funding mechanisms for trainees. So we need to create graduate, postdoc, and postdoctoral training mechanisms that include T32s, but go beyond T32s. We have talked about reducing the burden of applying for these training applications. So make them shorter, make them easier to apply for and easier to get through the review process. To expand the funding opportunities for preclinical research, to expand funding opportunities to non-US citizens. And that's certainly not just a pain-specific, but an NIH-wide issue. It's really difficult to find opportunities for trainees that are not US citizens when they want to do pain research. And then to generate more pain-relevant NIH study sections. Seventh goal is to expand our curriculum opportunities to create structured pain curriculum for medical and for graduate students, as well as for postdocs. Perhaps to offer courses in entrepreneurship, in innovation, and in finance to help our trainees learn how to do these critical things and potentially start companies. To enhance training for roles in industry and biotech, and then to strengthen communication skills, for example, between people with lived experience and the lay public. And finally, a last goal that we could think about so far is to provide more stability for pain research through infrastructure support and stronger infrastructure support. So to increase the number, for example, increase the number of pain centers of excellence. And in our breakout groups, we can talk about other ways to increase the infrastructure support. And so with that, that's the end of my presentation. Let me get out of this and go back to Zoom. Turn up everyone. Okay, so stop sharing. Stop share. There we go. Okay, so with that, I'd like to take us into our next breakout session where we can discuss our last two presentations and how we want to continue to funnel ideas down to our priorities. Jennifer, do you want to add anything here?
Nope, I don't think so. I think if people could really help us think about what do you think are the top priorities? Because again, we're going to be limited to 3 to 5. We've got lots of great ideas. We can put lots of things together, but they have to be kind of coherent. And so the prioritizing would be a nice contribution at this point. But again, continue the conversation too from before if you felt like it was cut off. We really want to hear everything. Thank you.
That's great. Thank you. And then at the end, we'll come back together after a break and we will have our leads in this new discussion group present a 2 to 3 minute summary of the high level new ideas from our group. Thanks so much.
All right, everyone will automatically be moved into a randomized breakout room.
Thanks, Sophia.
Okay, welcome back, everybody. I think this is the time where we have a bio break.
Right.
So we'll see you back at 4:15. Thank
Hello.
you.
Hello.
Okay. Welcome back from the break, everyone.
Hi.
Hi there. Okay. So our next task at hand is to spend the next 30 minutes in our large group discussion of the breakout rooms. And what I'd like to ask is for the leaders of the breakout rooms to give a 2 to 3 minute high-level summary of the discussion of the last two presentations, raising, anything we missed and priorities of things that were discussed, if possible. So I think we had 3 breakout groups this time. Great. So Carolina, were you part of a leader of group 1?
Sure, I can go. Stephanie,
Would you like to go?
You have some notes, so if I'm missing something, you can just jump in.
Sure, perfect. Thanks, Carolina.
No worries. So we had a very good discussion, and we actually started the discussion agreeing with all the successes mentioned, the Pain Research Center. We jump into a discussion about funding and decentralization within NIH, and Laura makes some comments about research decentralization within the NIH, and also specifically explain the NIH Pain Consortium that aims to reduce silos and connect researchers within the NIH and also outside. So I thought that was a very specific piece of information that clarify actually the discussion. We have some discussion on having perhaps senior pain researchers a space for them to share their wish list, project that they were unable to pursue perhaps in early careers, so they can share this data and they can connect with their investigator. I thought that was very, very great idea. Also investigate ways to make pain research data set more accessible to research in other fields such as epidemiology, biostatistics, to foster interdisciplinary collaboration. And we also mentioned that Purpose Network is doing this and has a specific purpose on that. We further explore, actually we have one of our members in our group that specifically investigate what the CIRTEC means from the cancer training. So she explored and she mentioned that they partner with elementary school and high school to provide initiative for kids to introduce the topic of cancer. So we thought that was very creative and how we can actually do something like that in pain. So explore opportunities to partner with schools and educational institutions to introduce pain research and awareness to students. So we further elaborate a little bit and perhaps to use the technology to get into new generations, understanding that new generation are learning in a completely different way that we learned when we were in elementary school or middle school. So we as a mentors and instructor and researcher, we need to adjust to the new minds. And also talking about adjusting, also that's related with the institution, the institutional support. Sometimes perhaps we have the lack of institutional support, and also some people are reacting against these new generational gap. So I think that's it. That's a kind of an overall view of the discussion.
Great, super, Carolina, thank you. Steph, did you have anything to add on that?
That was great, Carolina. I think the one last little thing on the point you were just talking about, institutional support for kind of younger generational things, including especially technology, how to include new technology that we just didn't use in research before.
Yeah, excellent point. Absolutely. Great. Thank you guys so much from group 1. Excellent presentation. So let's move to group 2. Alex, I think you were a leader of group 2.
Yep. We had a wonderful and wide-ranging discussion that, can kind of break into a couple different thematic buckets. First, as with group one, we had funding consideration discussions. There was consensus to fund or at least maybe not consensus, but there was a suggestion to fund investigators rather than specific projects. The K-24 being one mechanism of doing that, but not the only one. We touched on the topic of having a strong leader from the presentation, the first presentation, and Dan Claw made the point of one of the things that allows a leader to emerge is someone who has a lot of funding often within a department. And specifically, that comment was made in the context of other proposals to limit the number of, let's say, R01s per investigator, especially senior investigators. And that was an interesting point. And it seems like maybe having an abundance of funding, even though, sometimes it seems like an outsized amount going to one person, that's kind of where that strong leadership often comes from. And so that was an interesting point. We also talked about the flexibility in the definition of an early career researcher. Latasha pointed out that there are different kinds of career paths, specifically in her case, for example, being a veterinarian, and oftentimes if the ECR definition is too narrow, it limits folks from being able to take advantage of specific opportunities at specific times, or they're timed out of a specific window. We talked about research awareness and support. The importance of increasing public awareness about pain research and its significance. Tom asked how non-researchers, people with lived experience, private citizens can advocate for pain research, and we discussed how it's important to speak with your representatives and let them know the importance of pain research, and especially the importance of the people living with pain. We talked also about different career paths. How one of your goals, Cheryl, was number 4 was about like exposing students or trainees to different ways of staying within pain research broadly, and that doesn't just mean academia. And we talked about encouraging and exposing trainees to things like internships with local industry partners, having a seminar series of bringing people in who are doing other kinds of scientific activity that isn't just academic research. So we specifically talked about science writing, and having, let's say, a seminar series where folks who are doing this kind of science outreach, science writing, just to come talk to trainees, to even let them know these are the other ways available to you, and there isn't only just one way. I think that encapsulates a lot of what we talked about. If I missed anything, anyone from group 2, please jump in.
Okay. Great job, Alex. Great job, group 2. Wonderful. Okay, let's move to group 3. Kate, I think that's you.
It is. All right. We also had a lively discussion in our group. I'll try to hit some of the high points now, and feel free, other group members, to chime in if I missed anything. So first, we wanted to again emphasize the inclusion of people or persons with lived experience into this whole entire process. And I think reaching out, so not expecting them to come to us, but also us also reaching out to them was discussed in our group, right? So how can researchers get involved in, if there's a specific disease state that you study, get involved in interest groups locally for those groups, and then could that potentially be tied to funding, whether or not you're making sure that you're going sort of not even out of your way, but just making sure to include persons with lived experience in your entire research program. The second thing that we can highlight, we liked your curriculum development point, Cheryl, so that you had raised as one of the priorities. And so funding knowledge of pain is important, we think, just because it is so multidimensional and it affects so many people. So I think that we just wanted to emphasize the curriculum development point. Okay, so another sort of, I would say, major theme that was discussed in a few things that we talked about was this flexibility of training and how it doesn't always have to be so linear or prescriptive. So things that we discussed related to that are opportunities or funding specifically to pay undergraduates or internships that are normally unpaid. Could there be potentially ways of getting those people in and making sure that it's not just select people who don't need or can don't rely on like a summer job essentially to like stay afloat. So is there a way that we can bring in more peoples that way? Also, the idea of remote work. Are there funding opportunities that can be like specific calls for like exclusively remote work? So we had an example of a T32 that was recently funded that's entirely remote. And so that seems like a really interesting way of potentially not forcing people to uproot their lives every 4 or 5 years for different parts of their training. That might allow people to sort of like stay in the pipe or stay on the highway even longer. And then I think the last sort of gaps that we maybe haven't necessarily addressed so far that I wanted to highlight are, one, this idea of potentially funding brand new pain centers. So if there was a large amount of external support that came from the government, would institutions then be equally excited about putting more money like into specific places that don't have established pain centers yet? The second is funding for more intense community building opportunities. So things like the North American Pain School that people have attended. I think that that seems to be an excellent community builder from the people that have attended that. And so is there a way to fund programs like that? And then the last sort of programmatic funding opportunity would be the funding of either pain specific events or sort of like pain satellite symposia at larger meetings that happen. So things like USASP has been able to receive funding from NIH, and I think that's been incredibly helpful for that organization. So I think maybe I'm not sure it's been touched on a lot in this conversation today, so we just wanted to highlight that. So yeah.
That's excellent, Kate. Great work. Thank you, group 3. So now and I think that was the end of our group. So let's open up to the whole group to talk about these ideas, raise issues that you think are of utmost priority. Yes, go ahead, Jennifer.
Yeah, I just want to let you all know I have been taking notes while we've talked, and what I've done is I truncated Cheryl's slides. So you've got 1, 2, 3, 4, 5, 6, 7, 8. I've added some comments that I heard. Probably didn't get everything because I was trying to type and listen. And then I added number 9, funding for pain meetings at non-pain special societies and also pain schools.
And the other one that Kate mentioned was funding new pain centers.
Right. So that was, thank you. That was one of them that I didn't quite get. So Kate, you were talking about providing a group that doesn't have a pain center funding. Okay.
Yep.
So centers of excellence, both new and existing.
Established, yeah.
Yeah. Okay, gotcha. Thank you. All right. So it's now modified. So we wanted to make sure you had something, we all had something we were looking at to possibly help in the kind of the stage of the discussion.
Great. Thank you, Jennifer. So the floor is open. Ultimately, we'll have to begin distilling down these ideas to, 3 to 5 priorities, which is the subcommittee's ultimate goal. So feel free to discuss things that you think are of particular importance.
So one thing that and Flavia put it in there, we discussed in group 3, and now actually it's funny because Tom just put it on the chat as well, is really to think as, not only team science, but team science includes patients with lived experience, like going, all the way through the people that we're trying to impact, and they're a critical part of our team.
Mm-hmm.
And we had thought of that as sort of in number 5, so full range of translational team science research,
Mm-hmm. That's actually a great point. Thank you. Yes, I agree with that. Thanks, Yanazel. Brian, go ahead.
Yeah, I know we talked about, or I think it was group 1 or 2 talked about incorporating technology into the training. I also want to just advocate for maybe some sort of providing, when we're doing these things and building these communities, and providing money to institutions, maybe setting aside money to you know, not only incorporate that technology into the training, but also like provide it. I know myself as a trainee, I rely heavily on statistical analysis programs like GraphPad Prism. Luckily, my advisor and the training program that I was on was able to provide that to me, but I know that that is not consistent across the board in everyone's experience. So having those forms of technology that are critical to us performing the type of research and analysis that is necessary for our research is something else to think about.
Absolutely. It's a great point, Brian. And to add to that is, you know, for those of us that don't know how to code, I mean, that's become such a huge issue, and bioinformatics and all. So I think that is a place where we can really include training. Great point. Go ahead, Roger, please.
Thanks, Cheryl. So in order to prioritize by elimination, I wanted to make sure I understood one of the goals around leadership training. And so I guess my sense is that most academic institutions of size and many private organizations offer some really good leadership training. So I don't know that we need new leadership training. Probably what we need is protected time and support for the people who need leadership training to engage in it.
Yeah.
So that might be folded in one of our other priorities or goals, and maybe some encouragement from NIH or elsewhere for people to engage in leadership training would be helpful.
Yeah, I think that's a great point. Yes, really good point. I've taken a leadership course. I've never, but I had never had instruction on strategic planning or creating a mission or a vision. So I agree with you that I think that many institutes do have leadership programs. So maybe we need to encourage a merging of that sort of training with our pain constituents. It's a good point.
So what I did was I put that in number 1, because that could be part of career development awards, and your leadership training is the stage you're at. So it might be emerging leaders and then mid-career leaders and senior leaders, that kind of thing. So you could kind of, thank you, Roger.
Yeah, that's a good point. Yeah.
All right, so we're down to 8. That's easy.
Great. Other comments and thoughts on these goals or other things, priorities? Oh, sorry. Go ahead, Brian.
Yeah, so this question is more so to individuals with, or people with lived experience that that do have like what's the word I'm looking for? Kind of like federally recognized disabilities. And I don't know if there are people like that in the chat, but I'm wondering if like, is there a lack of understanding and how that that lived experience impacts their ability to effectively like be involved in research? Like, I don't know if institutions don't have like well-kept wheelchair ramps, or when they don't have like functional elevators and things like that. Like, have we addressed that and how that can impact recruitment and retention?
Yeah, that's a great point. We can certainly
Yeah.
include that. Go ahead.
Yeah, I'll jump in and say that I know at the last heel pain conference that was had, the 5th annual conference, they were offering travel awards to folks from the pain community, and they did try to make accommodations for folks who do have disabilities, but it was limited. And so I really I thank you, Brian, for bringing that up, because my mother was a double leg amputee on dialysis, and so access was always something that we were looking for and making sure that she had. And so I appreciate you bringing that up.
Great points. Excellent. Other thoughts? Well, I'll raise one on the curriculum opportunities regarding creating structured pain curriculum for both medical and graduate and postdoctoral researchers. I think the Purpose Network is working on that. I think Dr. Claw is involved in that with some others. So I believe that will be rolled out over the next year. So I'm really happy to see that. On the flip side, just while we were in this break, I was spoken to by the person who is the director of the medical neuroscience course for medical students, and she told me that now not only are my lectures on pain no longer needed, they had been reduced to a couple of podcasts, and now they're not even going to be showing those podcasts. Because those specific questions are not on the board exams. So it's ironic to me that at my own institute, my involvement in medical curriculum has become nothing anymore. And I used to be like, give 12 lectures. And yet at the same time, we're expanding trying to expand pain curriculum because it's one of the most common things that a physician will see. So Yenizel, you have your hand up.
It's sort of on a different point, so I don't want to. I think you have a really good. Yeah, you have a really good point. I raised my hand too.
Got it. Well, okay, I'll just finish that out. I mean, I just find it ironic that my services are no longer needed at my institute for training physicians.
So it's interesting because our dental school only got a pain course curriculum and all these things because it was, became a bigger part of the boards.
Yeah.
And so, it seems this is where awareness and kind of, other forces beyond us, right?
Yeah.
Are tied to a lot of what we're doing.
Exactly.
So, yeah. No, my point before, Cheryl, was actually I had a question, something that I wanted to bring up to the community because, it's really great to have things funded and all this stuff, but I think I know a lot of my trainees with funding, K awards, that are, don't have jobs, that can't find jobs. And I know a lot of different people around the country that I talk to that also, even with funding, they're not able to get jobs. And I think Roger mentioned something earlier about the perceived stability. And I don't know if this is potentially where having established pain centers would help, because then people that get K awards and are pain funded and, pain researchers then would be attractive to those pain centers, right? But there's not that many of those in the country. And, I'm trying to think, how do we distill this down, which is 9 things, but they may actually be related and sort of hierarchical, like what's going to give the biggest impact that will then trickle down, right? So I just wanted to throw that out there for you guys.
That's a great point, how to funnel this down and level it up so that we go for the biggest bang, right? Brian, go ahead.
Yeah. So thinking about the story you just shared, And like what Dr. Cruz was saying, I guess I'm trying to figure out like what would be the best way to really emphasize the necessity of pain, not only like pain researchers, but also pain studies in terms of like understanding how pain occurs and how like in the neurobiology behind pain. And I'm thinking kind of like how we talked about how pain is cross-disciplinary, really utilizing that as a way to get across to these boards and to these institutions that pain is a necessary component of almost all diseases that we suffer from. Like it's a dis-ease. You're more than likely in pain. That's kind of like the whole point. And I think maybe providing training, not necessarily in interdisciplinary, or in addition to providing training in interdisciplinary areas, also maybe having a mentorship in which you can emphasize how your research and how your expertise is interdisciplinary may help those individuals, like what Dr. Cruz was talking about, who are having troubles finding jobs. We study pain, but we study pain as kind of like, I don't want to necessarily say a subset, but like it's interrelated with the different disease states that we are interested in. So I'm not only bringing my expertise as a pain researcher, I'm bringing my expertise in cancer, in metabolic disease, in all different areas of research. And how do we curtail our resumes or our CVs that we're submitting for these job applications to really emphasize that as pain researchers, we are cross-spectrum in a lot of our expertise and what we bring to the table.
Excellent point. Yeah, excellent. I think, let's see. So I think I saw Eden's hand up, and then we'll go to Juan and then Latasha. Eden?
I actually think it was Juan's hand, but I just want to say that's really discouraging to hear, Cheryl, and I'm really sorry to hear that. And like as a trainee, not like taking with it like the lived experience portion, how discouraging to hear that in this training group. And it shows it just speaks to why that maybe having that mentorship and support at the other end or throughout the highway would be really beneficial.
I agree. I mean, in this case, it's talking to the administrators and the people that are controlling the curriculum, which is above my pay grade. So yes, I completely agree with you, and thank you, Eden, for that. Juan, go ahead.
Yeah, I wanted to reflect a little bit on what you shared, Cheryl, because that's terrifying and scary. Pain, I've always said, is one of the very few topics that truly are interdisciplinary, where interdisciplinary health education could be it's just a perfect case study, because you could bring dentists, nurses, physical therapists, pharmacists. So I've always thought that pain education and pedagogy education and research and pedagogy is such a fundamental gap that exists right now. And sadly, NIH has taken the position that they don't fund educational research, which I think when we talk about the mission of NIH, which is improve the health of the public, I think we really need to push against that idea that they're separate. Like funding educational research, when it deals with a health outcome, when it deals with such a big interdisciplinary issue as pain, there is a clear relationship in improving health outcomes. And I think investing in that pedagogy, I think, is extremely important, and something that we have the opportunity, hopefully, with this strategic plan to push NIH to go in that direction again. For those of you who might remember, there was the Centers of Excellence in Pain Education funding mechanism, which they didn't lead to much, sadly. But that doesn't mean that that type of investment in education and creating resources is not important. And you saw the case study with Cheryl. That's terrifying that clinicians, medical doctors, future medical doctors are not getting enough training. And I reflect on my experience as a pharmacist and teaching in the pharmacy curriculum, I mean, it's limited, but exists there. And even there's a new board certification in pharmacy, for clinical pharmacists on pain management. So I just think like we really need to push NIH to reconsider its position against not funding educational type research or pedagogy, because there is a direct relationship between what future and current clinicians are learning and what the outcomes of the society that they're going to be serving at will result in. And I think there's this idea of team science research. Why can we really come together, clinicians, pain researchers, and pedagogy experts, to come up with curriculum and ways to teach this curriculum in a way that creates a lot of awareness? Like, we are dealing with training of pain researchers and bringing awareness to pain research, but it all starts with understanding what pain is. And if we don't have that at the starting point of clinical education, I think we're just trying to swim across, like, against the current. So I just wanted to make the point that I think there should be a lot more investment in education.
Agreed, Juan. Thank you for raising that very much. Latasha, please.
Sure. So this is kind of in response to your comment, Cheryl, just a moment ago. I'd be kind of curious as to I guess which phase of boards it is that this pain is being phased out of, and or the pain education is being phased out of. And I'm curious as to whether there might be some opportunities then to kind of broaden the interactions, like at the college level. So at the level of kind of specialties and things like that, where maybe that's actually, you know, where the potential interactions, or where folks are kind of doing the deeper dive into pain mechanisms and what that actually means in terms of the patient and in terms of pain management, may play a role. So I just wanted to kind of bring that up as a person who's involved with both early kind of basic veterinary medical education, and then you know, I also see folks in the clinic as well, and so I think that just keeping in mind the clinic and the training that goes on after, that maybe some better interaction or better opportunities for people to really kind of get that education in other ways, with interactions at that level, both in kind of fourth year clinical experiences, but also in terms of internship, residency. I think some of those things may actually be some opportunities, even if they are unfortunately kind of weeded out of some of the earlier curricula that are catered to phase 1 boards, for example.
Sure. Latasha, thank you so much. And that was catered toward the phase 1 boards.
That's
correct. You're right. Yeah. Thank you. Alex, go ahead.
This is a very interesting discussion now of kind of medical education and pain. And Cheryl, thank you for sharing with me kind of what's going on in the classroom level by you. I want to just bring a maybe slightly different perspective from the practicing physician, from, let's say, residency through even late medical school. So I have no doubt that there might be a de-emphasis on some of the things that this audience thinks is very important about pain, myself included. So the medical students are definitely not getting taught about all the subtypes of DRG or different neuroanatomical pathways. No doubt about that. But I will say that they absolutely are learning the evaluation of different pains as a presenting symptom for example, abdominal pain. The differential diagnosis for different parts of abdominal pain is something that by the time medical students graduate, or any resident in internal medicine, that is a bread and butter presentation. Anyone in an ED or in an office-based person, like, they're doing that. Low back pain is such a common problem, and the fourth year medical students that I see, even without specific instruction, are able to ask the relevant questions about, is this mostly in your back or back plus leg? Tell me how it feels, right? Like, so I will say, from the standpoint of the clinical evaluation of different pains and possible interventions, I think that's a core competency that most are getting, no matter the field. But they're not learning about the psychological aspects of pain. They're probably not learning about the social aspects of pain. Many probably couldn't tell you about the anterolateral tract or different parts of the brain. But I want to reassure this audience that the docs are addressing pain, and they're not discounting it, and they're learning it, but probably just not in the way that we are used to thinking about it.
Okay, good. Thank you, Alex. That's reassuring. Thank you. Great. So other comments or questions? Jennifer, is there anything in the chat that we should raise?
Yep, I'm keeping track. Tom has given us some good superordinate categories: funding, training and education, institutional support, and public support. So I've got those noted.
Okay.
There are a variety of different kind of comments about the curriculum, and I think I agree with some of the comments that it's probably institutional dependent and course leader dependent. we have a 4.5 day curriculum for the first year medical students in pain that I was part of kind of contributing to for years. So let's see. I don't think there's anything that we haven't discussed. There's chatter back and forth. Oh, Yenisel said we need a campaign on pain. Pain is a public health problem. Hopefully people have seen that. I've got that noted too. Please speak up. If I've missed your chat, please help me out here. I'm scrambling to keep up with everything.
Okay. Anything else we haven't raised?
I don't think I don't have any completely new topics. We got rid of one through Roger's suggestion. Yeah.
Okay, great. So I think if you think of anything big that we have missed, please let us know. We've taken ample notes here, and there'll be an opportunity to send feedback again by email. If there's anything you think of later that we're missing, please do that. Please continue to think about how to prioritize and combine to put forth the most high level recommendations that our committee can do for training and workforce. And so just the next steps. So everyone participating in this call is going to get an email with a written summary, our slides from the 4 presentations, and a link to the recording of the entire session. Jennifer, did you want to say something?
I'm just going to say, and what will happen, sorry, you keep going. I don't want to interrupt you, but there's the email addresses in the chat when you get there.
Oh, okay, super. So yeah, and so these materials will be sent to you. They will also be available for dissemination, wide dissemination. For example, USASP is planning to disperse these materials on all of this that happened today. If you think of other ways we can disseminate, please let us know. Jennifer is putting in the chat the email address for you to give.
Rob did.
Okay, great. Rob's put in the chat the email address where you can give any additional comments on high-level priorities, anything we missed, and your thoughts on where we need to go next. And then our subcommittee and all of that will, and the reason we want you to send it to that email is so that it will all be on public record rather than sending it to either Jennifer or myself. We want you to send it to that email that Rob has posted. And then our subcommittee on training and workforce, we will meet by hopefully mid-December to refine our short list of priorities to put forth to the HEAL greater community or greater organizational executive committee. And with that, I'll ask, are there any questions or final comments? Okay, well, hearing none, I really want to thank you for all of this time that you spent with us today, all of your great openness and willingness to share your ideas and your thoughts and contribute to this really important conversation we're having. Please continue to send your ideas forth to that email address. And again, thank you on behalf of myself and Jennifer. Do you want to say any closing words?
No, I thank you all. It's been a long haul and we appreciate you hanging in there with us.
Okay, thank you everyone. And I hope you have a wonderful rest of your Monday.
Likewise.
Thank you.
Thanks.